Golden notes: polyarthritis nodosa, PAN. Definition: systemic vasculitis of the medium-sized vessels with necrotizing inflammation leading to aneurysm formation and tissue ischemia, most commonly involving skin, peripheral nerves, muscles, joints, gastrointestinal tract, and kidneys. Any organ with the exception of the lung can be affected. Epidemiology: peak incidence between 45 to 65 years. It's more common in males, more common in middle-aged men. It is a diffuse vascular inflammation and ischemia of the affected organs. PAN is a medium vessel vasculitis that is a type 3 hypersensitivity reaction. Association with hepatitis B infection. Remember, PAN, hepatitis B, so P with B. Features: non-specific symptoms found in 65 to 80% of patients. Fever, malaise, arthralgia, weight loss. Neurological involvement in 55% of patients. Polyneuropathy, mononeuritis multiplex. Cerebral ischemia. Skin involvement in 44%. Skin rash, skin ulcers, nodules, livido reticularis. Renal involvement in 11%. Hypertension and hematuria, and also renal impairment. Coronary artery involvement, increased risk of myocardial infarction. Gastrointestinal involvement, abdominal pain, nausea, vomiting. There is also testicular pain from ischemic orchitis, which is a characteristic feature. However, it is uncommon presentation. PAN usually spares the lungs. PAN should be considered in young adults presenting with stroke or myocardial infarction. The diagnosis may be confirmed with a biopsy of involved tissue. For diagnosis, you need 3 of the following criteria: weight loss more than 4 kg, livido reticularis, testicular pain or tenderness, myalgias, weakness or leg tenderness, mononeuropathy or polyneuropathy, diastolic blood pressure more than 90 mm mercury, elevated urea or creatinine, positivity for hepatitis B virus, arteriographic abnormality, biopsy of small or medium-sized artery containing polymorphonuclear leukocytes. Investigations: hepatitis B surface antigen is positive in 30%. P-ANCA is positive only in 20%. ANCA is classically negative in PIN. Angiography: conventional angiography is the imaging modality of choice and should be performed if there is a clinical suspicion of PAN. Typically demonstrates microaneurysms and focal narrowing in medium-sized blood vessels. Biopsy should be performed if angiography is not available or does not conclusively show a medium vessel vasculitis. Biopsy shows focal and segmental transmural necrotizing inflammation with fibrinoid necrosis in medium-sized vessels. Pleomorphic cellular infiltrate of lymphocytes, neutrophils, macrophages, and eosinophils. Granulomas are absent. Differential diagnosis: PAN are differentiated from the other small and medium vessel vasculitis by absence of antineutrophil cytoplasmic antibodies. Glomerulonephritis is not a feature of PAN, but it is common in antineutrophil cytoplasmic antibodies ANCA vasculitis. making this distinction early by way of urinalysis for protein, blood, and casts is a simple first-line test that can guide further investigations and treatment. Red cell casts are absent in PAN. If there is evidence of glomerular inflammation, such as urinary casts, then an alternative diagnosis such as microscopic polyangiitis or granulomatosis with polyangiitis Wegener's must be considered. Lung involvement is not seen in PAN, and abnormal respiratory findings should suggest an alternative diagnosis. And by confirmation that small vessels, arterioles, capillaries, venules are not involved. Treatment: idiopathic PAN, corticosteroids, and cyclophosphamide. Hepatitis B related disease, plasmapheresis, and antiviral agents. Azathioprine can be used as maintenance therapy and typically has fewer side effects than cyclophosphamide. Remember that cyclophosphamide causes premature ovarian failure and infertility in both men and women. This was provided by the SSSM Study Smart Series for MRCP, your easy way to easy pass. Don't forget to follow us on Facebook, Telegram, and YouTube channel. Thank you very much.